Hello everyone. I hope I'm live. Give me a minute to confirm. If I'm live, I will start the session ahead. You have to give me a minute to see. Yes, I hope it's working. Let me see. Yes, I hope it's working. So I guess the video and audio all good. So I welcome you all for today's session. A very good afternoon to all of you. I'm really sorry for being late. Due to some technical issue, I was unable to join. I guess everything is working right now. Is it, Aditya? Everything is working? So can you see me? Can you hear me? Can you see my PPT also? Can I start the session ahead? Okay. So I guess I must start. Okay. So I welcome you all for today's session. Today I am going to teach you a very important topic from pharmacology, one of the heart failure drug. We are going to complete it. That is Digitalis. All about Digitalis in a super duper simplified manner. I am going to teach you. So first I will teach you the introductory part, from where the Digitalis is obtained, what are the various types of Digitalis, then the mechanism of action, then the uses, then the side effects, then the contraindications, interactions, toxicity, everything about Digitalis. Now this topic is very important for second Prof University exam. You can get a long question on Digitalis. It's very common to get a long question on this, and also in competitive exam many questions come from this topic. So this topic is useful for all students, I guess. So before teaching you Digitalis, you must know that Digitalis is a drug which is used to treat the heart failure. It is an anti-heart failure drug. It is used to treat heart failure. So you must understand, ma'am, what is heart failure. First, if you understand the disease, then only you can understand the treatment. Without understanding pathology, you cannot understand pharmacology. Everything is integrated, you know. So you must understand what is heart failure. Then only you will be understand how Digitalis is used to treat heart failure, right? So let me first teach you what is the problem in heart failure. Heart failure can be of two types. It can be left heart failure, or else it can be right heart failure. So basically in heart failure, the ventricle, the left ventricle or right ventricle, left heart failure, left ventricle. In right heart failure, right ventricle unable to pump. By pump I mean systole. The systole is not very adequate. So if systole is not adequate, let's imagine the left heart failure. We will take the example of left heart failure. The left ventricle is not pumping properly, is not doing the proper systole. What will happen then? You imagine, if it is not doing the systole, the blood will not go into the aorta, or very less blood or inadequate blood will go to the aorta. So all the organs of the body will not receive pure blood, right? So all the organs will have hypoxia, will have ischemia, right? So hypoxic and ischemic changes will be in all the organs, right? And where the blood will go? The blood is not moving forward because the left ventricle is not pumping now. So blood is not moving forward. So where it is going? Basically the blood is going backward. So this is known as backward heart failure, right? So from left ventricle it is going to left auricle, from left auricle it is going to pulmonary vein, and from pulmonary vein all the blood will accumulate in the lungs, and patient will present with pulmonary edema, and patient due to pulmonary edema complains of dyspnea. So there is a patient will come to your clinic that, doctor, I am having two problems. Number one, I am having breathlessness, that is dyspnea. Even on small walk I feel breathlessness, that is I am having problem of dyspnea, number one. And number two, I always feel fatigue, lethargy, lack of energy, because all the body organs are receiving less blood, right? These are the two complaints, one due to forward failure, one due to backward failure, is faced by a patient in left heart failure, right? Now ultimately the patient is in your clinic and you want to treat the patient. You listening the symptoms of the patient, you have a suspicion that the patient have left heart failure. So the best investigation to do is a 2D echocardiogram. You just offer the patient, you do a 2D echocardiogram because I am having suspicion that you have a left heart failure. You auscultate the patient, you will feel like pulmonary edema here. On auscultation, you should feel like, right? So the lung sounds are not very clearly heard to you during auscultation also. And not the lung sound, I mean the heart sound. And do a chest x-ray. In the chest x-ray, the pulmonary edema is visible, and for the heart, do a 2D echocardiogram. The diagnosis is confirmed. Now it's time to treat. It's time to treat it. So what do you want to treat? You want to increase the systole of the ventricle. To increase the systole of the ventricle, there are some drugs which are known as inotropic drugs. Positive inotropic drugs. What does these drugs do? They increase the force of contraction. The drugs which increase the force of contraction of a ventricle are known as inotropic drugs. There are three types of cardiac inotropic drugs, right? Cardiac glycosides, which I am going to teach you today, that is Digoxin, Digitalis, right? Apart from which sympathomimetic drugs are there, dopamine and dobutamine, and PDE3, that is phosphodiesterase 3 inhibitors. These two categories we will take in some other session. But today I am going to teach you cardiac glycoside, one of the cardiac glycoside, right? So today I am going to teach you the cardiac glycoside, which is one of the inotropic drug which is used to treat the heart failure. Give me a thumbs up. You got it? Everyone give me a thumbs up. So let's start cardiac glycoside. So first tell me the classification, how many cardiac glycosides you know. Then tell me the mechanism. The most important cardiac glycoside I am going to teach you today, most important is Digitalis, right? So tell me the classification, tell me the mechanism of action, tell me the action, pharmacokinetics, uses, adverse effects, contraindication, interactions, all about Digitalis, right? Let's start. So what is a cardiac glycoside? Cardiac glycoside is the inotropic drug, right? That is, it increases the force of contraction. It increases the systole. It increases the force of systole in the ventricle. That's why it is used in the heart failure. So imagine this is the left ventricle. You are giving the patient cardiac glycoside. You are giving a tablet of Digitalis. So on taking the tablet, the left ventricle will start to do a forceful systole. The systole will become more vigorous, more contraction, more forceful. That is the meaning of inotropic drug. And this is how we are treating the heart failure. Okay, let me tell you how many drugs are there in this category. The name of the category is cardiac glycoside. कितने drugs आते हैं इस category में? So the main category in this drug, the main drug is Digitalis. You know, Digitalis is the umbrella term which is used for two terms, Digoxin and Digitalis. Digoxin and Digitoxin, both are together known as Digitalis. You know, so in your exam, either the question is coming on Digitalis, or the question is coming on Digoxin, or the question is coming on Digitoxin. You have to write everything same. They are not different. You have to write all the things same. There are some pharmacokinetic differences between the two, between the properties. I will tell you the differences. Otherwise, their mechanism of action, their uses, adverse effect, everything is. And together they are known as Digitalis. Give me a thumbs up if you got the overview. So what is Digitalis? What is Digoxin? What is Digitoxin? Apart from which, there are two more cardiac glycosides available. One is aubane, one is tryptophan. So total 4 cardiac glycosides are there. One is Digoxin, one is Digitoxin. Together these are known as Digitalis. The third is aubane and the fourth is tryptophan. Give me a thumbs up. You got it? Now Digoxin and Digitoxin both are obtained from plants. Both are obtained from plants. So you have to learn the name of the plants from which they are obtained, from the leaves of the plants. पेड़ की पत्ती से मिलते हैं. These are MCQs, right? So Digoxin is obtained from Digitalis lantana. It is the name of a plant. And Digitoxin is obtained from Digitalis purpura. It is also the name of a plant. So learn the name of the two plants. Got it? So Sachin, you got it? Aditya. Sachin, Aditya, Sukhram. Yes. So learn the name of the plants. Right. So after that, we have learned the 4 drugs in this category. Out of 4, 2 are important, Digoxin and Digitoxin. Let me tell you the most important thing, that is mechanism of action. The mechanism of action of inotropic drugs. So basically, I taught you that inotropic drugs are the drugs which increase the systole. They are increasing the force of contraction of the systole. So before understanding the mechanism of action of these drugs, you must understand how normal systole and diastole takes place. You have already understood this in physiology, in your physiology subject when you were in first prof, right? So physiology mein you have already understood how systole takes place, how diastole takes place, है ना? So first let me revise you that, then I will teach that how Digitalis increases the force of contraction of systole. पहले normal systole कैसे होता है वो तो समझ में आए, ठीक है? So this is the heart. Now in the heart we have SA node. SA node is the pacemaker. Where it is situated? SA node कहाँ पर होता है? Does anyone know? Sachin, you know where is the SA node? David, do you know? Osama, where is SA node situated? So SA node is situated here in the left auricle and this is the pacemaker. From SA node, the wave of depolarization arises, right? This wave of depolarization goes everywhere, and wherever this wave of depolarization is going, that portion of the heart shows contraction. So when wave of depolarization is coming to the left ventricle, right? So let's start from that. Now in this diagram, I will show you the mechanism of action of Digitalis. First, you understand what is this cell. This cell is one of the cell of left ventricle. Let me draw it. Can you see this is the wall of the left ventricle? Can you see I am drawing the green color cells? These cells are present in the myocardium of the left ventricle. Let me zoom out one of these cells. So this is one of the cells. Can you see this is the cell membrane? So this is one of the cell which is present in the myocardium of the left ventricle. Students don't have even imagination कि ये cell आया कहाँ से? ये cell क्या चीज़ है? कहाँ से आया ये cell? This cell is left ventricle myocardial cell. Right? Give me a thumbs up. Give me a thumbs up. Right? Now when wave of depolarization is coming to this cell, what happens? Listen, on the surface of this cell, I will draw this cell for you. I would like to draw this cell. See, this is one of the cell I am drawing, left ventricular myocardial cell. Okay. Now when wave of depolarization is coming now, on the surface of this cell, calcium channels are present. L-type calcium channels are present, but they are closed. They are closed. When wave of depolarization is coming here, at that time they open. At that time they open. When they open, 1% of calcium goes in. Only 1%, a small amount of calcium. A small amount of calcium goes in. Cytoplasm of the heart cell do not have calcium. But now, due to the wave of depolarization, a small amount of calcium already entered inside. They already entered inside. You got my point? Now, inside the heart cell, there is endoplasmic reticulum, sarcoplasmic reticulum. Let me draw. Now, inside this, abundant of calcium is present. It is not free calcium in the cytoplasm. The calcium is present inside the sarcoplasmic reticulum of the cell. Now, this small amount of calcium, after going inside, on these, it will go to the sarcoplasmic reticulum. This is sarcoplasmic reticulum inside which abundant of calcium is. This small amount of calcium will go here, and on their surface, another receptors are present, which are known as RER, Reynolds, RYR, Reynolds receptor. So this small amount of calcium stimulates the Reynolds receptor. They get stimulated, they will open, and abundant amount of calcium, all the calcium present inside the sarcoplasmic reticulum also come in the cytoplasm. So basically 1% is coming from outside and remaining 99% is coming from the internal storage only. So total 100% calcium is present in the cytoplasm now. First give me a thumbs up everyone, you got this? What I am saying? This is a cell. This cell is the cardiac myocyte. That is left ventricular cell or right ventricular cell, the ventricular cell. When wave of depolarization is coming from the SA node, it is reaching to this cell. At that point, on the surface of this cell, calcium channels are present. L-type calcium channels, they will open. When they will open, a small amount of calcium enter inside. 1% you can say, a small amount. This 1% stimulate the release of remaining 99%. How does it stimulate the release of remaining 99%? The remaining 99% calcium is present in sarcoplasmic reticulum inside the cell. So this 1% calcium going to sarcoplasmic reticulum. On the surface of sarcoplasmic reticulum, there are receptors present. The name of receptors are Reynolds receptor. They will stimulate the Reynolds receptor. Once the Reynolds receptor, they are stimulated, they will open, and the remaining all the calcium, abundant calcium, 99% calcium, which is stored in sarcoplasmic reticulum, it will come out. So basically the cytoplasm of this cell is flooded with calcium. It's flooded. In the cytoplasm, 1% is coming from outside and 99% is coming from sarcoplasmic reticulum. Ultimately, cytoplasm have abundant of calcium. Give me a thumbs up everyone. Everyone. Now this calcium will go to actin myosin. You know, there is actin and myosin present inside the cell, which cause contraction of the cell. So actin and myosin, they will do contraction only if calcium comes and stimulate the tropomyonin. If tropomyonin will get stimulated because of calcium, then actin myosin contraction takes, and this cell will go in the system. Got my point? So when calcium is coming, 100% calcium is coming, it is going to tropomyonin, stimulating actin myosin, and actin myosin contraction taking place, basically systole taking place. You will say, ma'am, we got it, how the systole occurs. Now, systole is not permanent. Now, in my heart, in your heart, we have heartbeat. We have in 1 minute, the normal heartbeat is 70 to 100, 80 to 100, right? Our heart beat 100 times in a minute, right? On an average, 70 to 100 times in 1 minute. So, in 1 minute, we have 100 systoles, 100 diastoles. So, it is not permanent sequence. You got the point? So, after systole, it has to do the diastole. Relaxation. How does the relaxation will occur? First see, इसमें systole देखो कहाँ पे है. See, as soon as wave of depolarization is coming, this is the L-type calcium channel. It is opening. Can you see calcium channel? And 1% calcium is entering inside this cell. This is 1% calcium entering inside the cell. Everyone see. This 1% calcium is going to Reynolds receptor, RYR. Reynolds receptor, which are present on the sarcoplasmic reticulum. Give me a thumbs up. It got stimulated and remaining calcium is coming out. So all 100% calcium is going to actin myosin. Actin myosin is causing contraction, so contraction is done. Contraction is done. Give me a thumbs up. Let me draw the same cell again to explain you the diastole. This is the cell, the same cell, the myocardial cell, left ventricular myocardial cell. Till now I told you on the surface L-type calcium channels are present. These are L-type calcium channels. I told you this is sarcoplasmic reticulum. On the surface of sarcoplasmic reticulum, RYR receptors are present, Reynolds receptor are present. Till now what has happened? 1% calcium coming from here, 99% calcium coming from here. So all the calcium is causing the contraction due to actin myosin assembly. It is causing contraction. Now the contraction is already over. Actin myosin contraction is done. As soon as contraction is done, this calcium will go back. हिंदी में कहूँ तो जो जहाँ से आया वो वहाँ पे जाएगा. The 1% want to go outside, reverse outside, and the 99% want to go inside the sarcoplasmic reticulum to reverse the effect, to do the relaxation. So on the surface of sarcoplasmic reticulum, there is another receptor. The name of that receptor is SERCA, S-E-R-C-A. I will tell you the full form. SERCA, S-E-R-C-A, SERCA. This SERCA will take the 99% of the calcium. SERCA बोलेगा जितना रेनॉल्ड ने तुमको दिया है ना उतना तुम मुझे वापस दे दो. रेनॉल्ड ने तुमको कितना दिया है, हमारा कैल्शियम हमें वापस दे दो. Whatever calcium sarcoplasmic reticulum given to you, please give it back to us. RYR releases calcium outside. SERCA takes calcium again inside. Both are receptors present on the sarcoplasmic reticulum. But it will not take more, it will not take less. Whatever calcium given by RYR is taken back by the SERCA. This is the punchline. Give me a thumbs up. Give me a thumbs up. Yes, yes, Sachin, give me a thumbs up. So the 99% is already gone. 99% is already gone. Now what is left? The left is the 1%, which was coming from the calcium channel. This 1% is still present inside the cell. Now we want to get rid of this 1% also. Yehi 1% pura khel karega, right? We want to get rid of this also, right? Now on the surface of this cell, there is another transporter which is known as sodium calcium exchanger, NCX. Say the full form. Say the full form. Sodium is Na, that is N. Calcium is Ca, right? NaCa exchanger, NCX. Okay. So this 1% will go to this exchanger and request कि please मुझे बाहर भेज दो ना, मेरा काम हो गया है, my job is done, please let me go outside. You are sodium calcium exchanger now, I am calcium, please take me out. So this exchanger will say, okay, I am ready to take you out, but instead of you, I have to take sodium inside. I have to take sodium inside because I am sodium calcium exchanger. You want to go outside, you go outside. But in exchange of you, I will take sodium inside. So one molecule of calcium go outside, Ca2 positive, and 2 molecule of sodium come inside, Na1 positive. Give me a thumbs up. Give me a thumbs up. So all the calcium is, 100% of the calcium is get rid of. The 99% is going back into the sarcoplasmic reticulum by SERCA, and remaining 1%, which was coming from outside from calcium channel, L-type calcium channel, it is also going outside the cell by NCX. But in exchange of which, we are having sodium inside the cell. Listen, अब इस सोडियम का क्या करेगा सेल? सोडियम क्या करेगा सेल का? सेल क्या करेगा सोडियम का? So on the surface of this cell, there is third transport, which is known as sodium potassium exchange. Sodium potassium transporter. So this sodium, which is coming in exchange of calcium, it will go out again. अंदर आ जाएगा कैल्शियम को हेल्प करने के लिए, लेकिन बोलेगा मेरा कुछ काम नहीं, मुझे वापस बाहर जाना है. ये वापस बाहर चले जाएगा और इसकी जगह पे आ जाएगा पोटेशियम, that will remain inside the cell only. So this is the complete story. If you got this, now learning the mechanism of action is Digitalis is fun for you. Everyone give me a thumbs up first. Osama, you got it? Aditya, Sachin, David, you got it? Others, give me a thumbs up. I am revising again. Everyone see. ये सेल में फिर से बनाऊंगी, the same cell given here, और उसी सेल में I will tell you the mechanism of action of Digitalis. First you tell me systole कैसे होगा और diastole कैसे होगा. You tell me both. How systole occur, how diastole occur. You tell me both, right? Then I will tell you how Digitalis increases systole, not diastole. It increases only systole, but not diastole. I will tell you what, right? So can you help me? Can you help me? I want this cell to contract. Okay, let me draw the sarcoplasmic reticulum of this cell. This is sarcoplasmic reticulum of this cell. Yes. So what happens when wave of depolarization is coming? This is wave of depolarization. It is coming from the SA node. It is reaching this cell. When this wave of depolarization is reaching this cell, on the surface of this cell, L-type calcium channels are present, they will get open. So when they open, a small amount of calcium will enter inside, a small amount, right? This small amount of calcium will go to sarcoplasmic reticulum. On the surface of sarcoplasmic reticulum, RYR receptors are present, Reynolds receptor, right? Reynolds receptor, yes. So they will stimulate the Reynolds receptor. On stimulating, Reynolds receptor will open and all the calcium remaining, the 99% of the calcium present inside, it will also come out. So basically in the cytoplasm, we get calcium from two sources. A minor source is from outside and a major source from the sarcoplasmic reticulum. So the cytoplasm is flooded. Cytoplasm is flooded with calcium. All the calcium will go to actin myosin assembly and causes the contraction, causes the systole. So systole is over. Systole is over. Everyone give me a thumbs up if systole is over and if it is understood to you. This is how systoles take place. Now coming on diastole. As soon as the systole take place, systole ho gaya na? We do not want to continue systole. This sarcoplasmic reticulum, on its surface there is another receptor. The name of that receptor is SERCA. SERCA. I will tell you the full form. Okay, SERCA. This SERCA will take the calcium given by RYR. Whatever Reynolds receptor have given the calcium, that is taken back by SERCA. इसने 99% दिया था ना, ये बोलेगा हमें हमारा तो वापस करो, है ना? तो हमने तुम्हें उधार के लिए दिया था and you give it back to us. हमें ज़्यादा नहीं चाहिए, हमें कम नहीं चाहिए. Whatever calcium given by RYR, give it back to me. That is the role of SERCA. So they will take back the 99% of the calcium. Still 1% is left, which is coming from outside, from the L-type calcium channel. उसको बाहर निकालने के लिए this 1% want to go outside. So there is another transporter present on the surface of the cell, which is known as NX. Sodium calcium exchanger. This 1% calcium will go to that transporter and request the transporter, can you please take me out? My job is done. My job was to do the systole. I have done the systole. I want to go outside. So this exchanger say, okay, I will take you outside, but in exchange of you, I will take sodium inside because my name is sodium calcium exchanger. So calcium will say, okay, I want to go outside. You take sodium inside. So calcium is going outside. So no calcium is present in the cytoplasm now. 99% is taken back by SERCA and 1% is taken out by NCX. Both are functional. Okay. So learn four sources, four receptors. 1% आता कहाँ से है, 99 आता कहाँ से है, 1 जाता कैसे है, 99 जाता कहाँ कैसे है. You got my point? So you have to learn the name of the four receptors, four transporters. ठीक है, all four are functional. So 100% calcium is rid of. But इस 1% को निकालने के चक्कर में सोडियम अंदर आ गया. ठीक है, the sodium will say, what I will do inside? There is no job. I want to go out again. So there is another transporter known as sodium potassium ATPase channel. ये सोडियम उसके पास जाएगा कि मुझे वापस बाहर जाना है, वो तो मैं कैल्शियम की हेल्प करने के लिए आ गया, वरना मेरा कोई काम नहीं है यहाँ, तो मुझे वापस बाहर भेज दो. So this sodium will again go outside and in exchange of which potassium will come and potassium will remain inside only. Give me a thumbs up if you got it. Everyone give me a thumbs up. See, everyone see here. Everyone on this gazette. See here. Listen, now I'm telling you the mechanism of action of Digitalis. You tell me Digitalis is an inotropic drug. So inotropic drug increases systole or diastole? I'm asking you. Aditya, I'm asking you. Yes. You want to increase systole or you want to increase diastole by giving Digitalis? What do you want? Of course, you want to increase systole. You want to increase the force of contraction because Digitalis is the anti-heart failure drug. You want to treat the heart failure, no? So Digitalis, mind my words, blocks sodium potassium channel. Sodium potassium channel, this one. This is blocked by Digitalis. This is the mechanism of action. And by doing so, the systole is increased. And how by doing so systole is increased? Let's explain again. Okay, come. We will study the same cycle from the beginning. ठीक है? शुरू से फिर से शुरू करो. ठीक है? As soon as wave of depolarization is coming, start saying. You all start saying. As soon as wave of depolarization is coming, it is coming to this cell. So L-type calcium channel will open and 1% calcium will go inside. This 1% calcium will go to sarcoplasmic reticulum, stimulate the Reynolds receptor. Reynolds receptor gets stimulated and release the 99% of the calcium. So cytoplasm have 100% of calcium. Till now story is same. There is no difference in story. ठीक है? 100% calcium will go to actin myosin and it will cause contraction, it will cause systole. Till now story is same. You will say, ma'am, what is the difference till now? Okay, difference अब आएगा. ठीक है? Now systole is over. Systole is over. Now what happens next? You tell me. Immediately after systole, the 99% calcium is taken back by SERCA. ये 99 तो अपना चला जाएगा. जितना RYR ने दिया, 99% taken back by the SERCA into the sarcoplasmic reticulum. Lekin, 1% calcium is still present in this, right? Normally, where does it go? Normally, I'm asking. So this 1% calcium go to NCX, this NCX, and request NCX, can you please take me out? My job is over. My job was to do the systole. My job is over. Please allow me to go out. So NCX will say, I will only allow you to go out if sodium come in, because I am sodium calcium exchanger. So calcium say, okay, you ask sodium, if sodium is ready to come in, please let me go out. So sodium will say, no, I will not come in. This time sodium will say, no, sodium अंदर नहीं आएगा. Why sodium will not come in? Sodium बोलेगा कि मैं अंदर जाके क्यों फंसूं? Because sodium will come in. Normally when sodium was coming in, it was going out by sodium potassium exchange. But now sodium potassium exchanger is blocked by Digitalis. So this is non-functional. This is non-functional. So already abundant of sodium is present inside the cell. It is unable to go out. Already abundant of sodium is present. So this NCX will also not work, because already there is abundant of sodium. तो कैल्शियम को बोलेगा कि तुझे बाहर जाने दो, तो सोडियम को अंदर लेना पड़ेगा, लेकिन सेल में तो भरमार है सोडियम की, तुझे मैं कैसे जाने दूं? और सोडियम अंदर आ जाएगा, तो हम तुझे बाहर नहीं जाने देंगे. I will not allow you to go out. So this 1% calcium is trapped inside the cell technically. This 1% calcium is trapped inside the cell technically, and again it will go to RYR. ये बोलेगा चलो कोई नहीं, फिर नहीं जाऊंगा तो अपना काम करता रहूंगा. Again it will go to RYR, stimulate RYR, and the same story is repeated. So systole is exaggerated. This is how inotropic drugs work. Give me a thumbs up. Give me a thumbs up. Am I back? Can you see me? Am I back? I guess I am back. Yes, I guess it's working now. Yes? Give me a thumbs up if you can see me, can hear me. It was stuck, no? Now is it working? Can we go ahead? So this is the mechanism of action. So can you tell me, first tell me normally how does it occur, and then tell me the mechanism of action of Digitalis. So normally, say like this. During depolarization, as soon as the wave of depolarization is coming, 1% calcium enters through L-type calcium channel. This 1% calcium go to RYR. The full form of RYR is Reynolds calcium channel present on the sarcoplasmic reticulum. So it will stimulate the sarcoplasmic reticulum, and large amount of calcium will come. 99% will come in the cytoplasm. So basically, the cytoplasm is flooded with calcium transient. This will go to troponins, stimulate troponins, and it will go to actin and myosin. And actin-myosin contraction takes place. This is how contraction takes place. Immediately after contraction, SERCA is stimulated. What is the full form of SERCA? What is the full form of SERCA? Tell me. SERCA, it's sarcoplasmic endoplasmic reticulum calcium ATPase. Sarcoplasmic endoplasmic reticulum calcium ATPase. So this is the full form of SERCA. It will get stimulated, and it will pump back all the calcium which was given by RYR. So 99% is already pumped back, but a fraction amount of calcium is still remaining inside the cell. What fraction? Which is coming inside from L-type calcium channel. That will go to NCX, that is sodium calcium exchanger. So it will take the calcium out, and in exchange of calcium, it will take the sodium in. This sodium which is coming, it will go to sodium potassium transporter. So here in the diagram also you can see, this is 100% calcium. This 100% calcium already done the contraction, actin-myosin contraction. Now it want to go out, right? So 99% of this is going back by SERCA. See, 99%, and 1% is going to NCX. This is NCX. Can you see it is going 1% out by NCX? In exchange of it, sodium is coming in. Whatever sodium coming in, it is going out by sodium potassium ATPase. In exchange of that, potassium is coming in. You got it? Give me a thumbs up, everyone. David, you got it? Now tell me the mechanism of action of Digitalis. Who will tell me? What does it do? Digitalis inhibit. What does it inhibit? I guess, I don't know, due to some technical issue, some stucking is taking place. Okay, let me continue. So already this cell have abundant of sodium, because sodium potassium ATPase is not working. So this cell have abundant of sodium. Since it is having abundant of sodium, so NCX will not work. If NCX will not work, so 1% calcium would remain trapped inside the cell only, and again that 1% sodium stimulate RYR, and it will cause continuously systole. So there is accumulation of intracellular calcium, 1%. This 1% again go to sarcoplasmic reticulum, stimulate again and again it is causing the contraction. So it is known as inotropic effect. Give me a thumbs up. Yes, you got it? You got it? So this is the mechanism of action of Digitalis. So Digitalis inhibits sodium potassium ATPase. By doing so, the sodium cannot go outside. So intracellular concentration of sodium will increase. So sodium calcium exchanger NCX will not work. NCX will not work. If NCX will not work, so 1% of the calcium cannot go out, and again it will go and it stimulate the sarcoplasmic reticulum. So it will cause more and more contraction. More and more contraction means inotropic effect. So this is how we can get the inotropic effect by Digitalis. I guess I tried my best to explain you the mechanism of action. Is it? Can I go out? Can I move to the next thing? Yes? Okay. Okay. Now here, David, I want to tell you two things. Sachin, Osama, I want to tell you two things. If you understood the mechanism of action of Digitalis, tell me two things. What is the effect of hypokalemia, and what is the effect of hypercalcemia on Digitalis functionality? You have to understand one thing. Digitalis inhibits sodium potassium ATPase. Now, when Digitalis was absent, how this pump was functioning? When Digitalis was absent, how does this pump was functioning? When there is no Digitalis, sodium was coming out. And potassium was going in. Potassium, am I right? Potassium was going in. This was happening normally. But when Digitalis is coming now, Digitalis also want to come in like potassium. Digitalis also want to come in, right? Because when Digitalis will come inside, then only it can inhibit the pump. Otherwise, it cannot inhibit the pump. So basically, I want to say there is a competition between the potassium and Digitalis. There is a competition between potassium and Digitalis that who will go in. जो ज़्यादा होगा वो अंदर जाएगा, सीधी सी बात है. The one who is in more concentration, that will go inside. So if there is hyperkalemia, less Digitalis will go in, and if there is hypokalemia, more Digitalis will go in. So hypokalemia is dangerous. If there is hypokalemia, na, more Digitalis will go in. And it will cause Digitalis toxicity. In Digitalis toxicity, इतना ज़्यादा systole होगा कि patient can go in arrhythmia. We do not want that. Give me a thumbs up if you got it. So hypokalemia can lead to Digitalis toxicity, not hyperkalemia. You got my point? Potassium and Digitalis both compete with each other to go inside. So basically they are inversely proportional. If potassium is more, less Digitalis will go. If less potassium is there, more Digitalis will go. Got my point? So basically hypokalemia causes Digitalis toxicity. This is my answer to you. Yes. Digitalis act from the outer side or inner side? Sachin, from the inner side. That's why there is a competition between the potassium and Digitalis. Once Digitalis will go inside, then only from inner side it can inhibit, right? So hypokalemia, listen my words. Digitalis bind to the potassium binding site of this enzyme. There is a competition between the two. Which two things? Potassium and Digitalis. There is a competition between the two. So if potassium is less, Digitalis will more, and it will lead to Digitalis toxicity. In second Prof University exam, this question is very common, that why hypokalemia leads to Digitalis toxicity. Please explain in one line. You have to simply give the answer. There is a competition between potassium and Digitalis to go inside. So if there is less potassium, more Digitalis will go inside, and it will lead to Digitalis toxicity. Give me a thumbs up. So this is a very commonly asked question in Prof University. Got it? You got it? So this is the thing. And what about calcium? So more calcium, more Digitalis toxicity. Because basically Digitalis कर क्या रहा है? Ultimately it is increasing calcium, और calcium पहले से ही ज़्यादा है, तो it will lead to Digitalis toxicity. So there are two reasons for Digitalis toxicity: hypokalemia and hypercalcemia. Both leads to Digitalis toxicity. Never forget. Please learn it. Right? Very important MCQ. We are done with mechanism of action. Now I'm coming on the actions of Digitalis. Action on 4 organs: heart, blood vessel, kidney. Let me start with heart. In the heart, what does Digitalis do? Tell me 3 things in the heart. Number 1, tell me what does it do to the contraction, force of contraction. Does it increase or decrease on giving Digitalis? Number 2, tell me the excitability. What does it do to the excitability? Excitability मतलब SA node को क्या करता है? Is it increased or decreased? And third, tell me the heart rate. Is it increased or decreased? Tell me 3 reasons. The force of contraction, of course, increased. We have seen the mechanism. How does it increase in the systole? It's an inotropic drug. SA node को भी ये stimulate करता है, इसलिए excitability भी बढ़ती है. It is causing because of which Digitalis can cause arrhythmia. Digitalis is a arrhythmic drug. It can lead to arrhythmia when it is more because it is increasing contraction. वो तो हमें करना ही है. We are giving Digitalis for heart failure. ठीक है? So basically we want to increase the force of contraction. But apart from increasing the force of contraction, it also increases the excitability. तो ज़्यादा हो गया अगर तो it can lead to arrhythmia because of more excitability. ठीक है? And heart rate is reduced. Heart rate is reduced. So it causes bradycardia. It causes bradycardia. The heart rate is reduced because Digitalis stimulates parasympathetic, the vagus now, parasympathetic system. So it causes bradycardia. So 3 things you have to learn. It increases the force of contraction. That's why it is useful in heart failure. It increases the excitability. Listen, it increases the excitability. That's why it leads to arrhythmia. And it decreases the heart rate. That is, it causes bradycardia. That's why it is used to treat arrhythmia. Arrhythmia क्या होता है? In arrhythmia, the excitability is more now. You want to reduce the heart rate. Now, Digitalis is a drug which can lead to arrhythmia, which is used to treat arrhythmia. It is arrhythmogenic as well as used in the treatment of arrhythmia. Yes, yes, Digitalis is a drug. जिससे arrhythmia होता भी है और arrhythmia के treatment में भी हम उसे use करते हैं. You got my point? You got my point? So yeah, this thing is very tricky. You must understand. So the 3 effects on the heart are in front of you. ठीक है? So force of contraction, what will happen? Force of contraction, it is a positive inotropic drugs. That's why it is increasing the force of contraction. Force of contraction. ठीक है? So the second is increased excitability. Increased excitability. Excitability is increased because it stimulates SA node. That's why cause arrhythmia. ठीक है? And third is the heart rate. It decreases heart rate. It leads to bradycardia. It decreases the heart rate because it causes the vagal stimulation, the parasympathetic stimulation. So learn the 3 things. If you have learned the 3 things, you can understand it. So that is the effect on the heart. Blood vessel, not very important. You can leave. There is no effect on the blood pressure basically. Kidneys may be not important. Yeah, CNS. In the CNS, it causes CTZ stimulation. Digitalis cause CTZ stimulation. That's why it causes nausea and vomiting. The most common extracardiac side effects is nausea and vomiting. So that is the action. You have seen the mechanism of action. You have seen the action. Now coming on pharmacokinetics. Pharmacokinetics, you have to compare the pharmacokinetics of Digitoxin and Digoxin, the 2 types of Digitalis. The 2 types of Digitalis. Adikya, CTZ is the area in the brain that is known as vomiting center. It is not covered by blood-brain barrier. CTZ area is not covered by BBB. That's why Digitalis can easily reach to CTZ and stimulate CTZ, and by stimulating so the patient like nausea and vomiting. Give me a thumbs up, right? In pharmacokinetics, you have to compare the 2 types of Digitalis, Digitoxin and Digoxin. Digitoxin is obtained from a plant known as Digitoxin purpura, and Digitalis is obtained from a plant known as Digitalis lantana. Oral absorption of Digitoxin is 100%, and that of Digoxin is 80%. Plasma protein binding पे MCQ आता है. It is 95% for Digitoxin and 25% of Digoxin. You have to learn that. Excretion, elimination, it is hepatic here, it is renal here, right? So you have to learn the pharmacokinetics. There is nothing to understand there. We have seen the classification, mechanism of action, actions, pharmacokinetics. Now coming on uses. Only 2 uses of Digitalis. One you already know. Tell me the 2 uses. Aditya, can you tell me the 2 uses? Osama, Sachin, anyone, the 2 uses. One we already know, the heart failure. In heart failure, we give Digitalis. Why we give Digitalis in heart failure? Because it is a positive inotropic drug. Basically, it increases the force of contraction. That's why we give it in heart failure to treat heart failure. Number 2, it is used to treat arrhythmias also. Arrhythmias, because it decreases heart rate. It causes bradycardia. That's why we use to treat arrhythmias also. वो बात अलग है कि ये arrhythmia करवा भी सकती है. Yes, yes. There are only 2 uses. Number 1, heart failure, and number 2, arrhythmia. You should know the reason for them. ये second prof में सारे one-liners हैं. Why Digitalis is used as a heart failure drug? Because of its inotropic effect. And why Digitalis is used to treat arrhythmia? Because of its bradycardia effect. दोनों में Digitalis है, लेकिन action अलग-अलग है. I have told you ना, in the heart, Digitalis have 3 actions. What is the action on contractility? What is the action on excitability? And what is the action on क्या कहते हैं, heart rate? What is the action? So Digitalis increases contractility, increases excitability, but decreases heart rate. You should know the reason for them, right? What is the reason for each of them? Can you tell me? It increases contractility. I have told you the mechanism of action because it inhibits sodium, potassium, ATPase channel. By doing so, it is increasing the contraction, it is increasing the systole. That's why increasing the contractility. It increases the excitability because it stimulates SA node. More SA node stimulation, more pacemaker, so it increases the excitability, and it decreases the heart rate because it stimulates the vagus nerve, that is parasympathetic nerve. That's why heart rate is reduced, that is causing bradycardia. Now tell me the consequence of each of them. It increases the contractility, that's why used in heart failure, right? It decreases heart rate, that's why used in arrhythmia, but it increases excitability, that's why it causes arrhythmia, not used. It causes arrhythmia because of this property. The property is different, you should understand the meaning behind them. Ye sab one liners hai. You got it? Give me a thumbs up. I tried best. So that is, you should learn the two uses, only two uses. Adverse effect. Tell me one extracardiac adverse effect and one cardiac. Extracardiac mein I have already taught you one adverse effect, nausea and vomiting due to CTZ stimulation. So extracardiac and cardiac adverse effect. The safety margin of Digitalis is very low. So safe margin is 1.5 to 3, the therapeutic range. Below 1.5 it will not work, and above 3 it will cause the side effect. ठीक है. Extracardiac में the most important is nausea vomiting due to CTZ stimulation. There are many, but most important is nausea vomiting. जिसमें बहुत MCQ आता है due to CTZ stimulation. Yes, so learn that. And cardiac में it causes arrhythmia. It causes arrhythmias because it increases the excitability. It causes all arrhythmias, all type of arrhythmias, tachyarrhythmia, ventricular arrhythmia, supraventricular arrhythmia, AV block, bradycardia, it can cause all. Except Mobus type 2 and atrial flutter. Except these two arrhythmia, it can cause any type of arrhythmia. Give me a thumbs up. So these are the, just a second. These are the side effects. So we have seen everything about the Digitalis. Now it's time to see its toxicity. Yes, it's time to see its toxicity. Can you tell me the factors which causes the toxicity? Digitalis toxicity. When Digitalis now you understood now. Adverse effect, I told you two type of adverse effect. The extracardiac is not very important, that's nausea and vomiting. It's okay. But cardiac one are the dangerous. The patient can die because of arrhythmia, right? Arrhythmias are very dangerous. Patient can die because of arrhythmia. You do not want in your patient that arrhythmia should happen, right? That's why you do not want Digitalis toxicity. So tell me the predisposing factors of Digitalis toxicity. I have already explained you decreased potassium and increased calcium. Both can lead to Digitalis toxicity. I have told you the reason also. Decreased potassium and increased calcium. Increased calcium, decreased potassium leads to decreased magnesium also. So basically you have to learn 3 electrolyte. Decreased potassium, decreased magnesium and increased calcium. They all can lead to Digitalis toxicity. Learn 3 electrolyte. ये तीनों avoid करना है. So you are a doctor, there is a patient in front of you who is in heart failure. You want to, is it? I guess again and again it is happening. Anyways, it is reconnected again, I guess. Okay. So you always have to check electrolytes if your patient is on Digitalis before starting the treatment, and midway also in your treatment you have to go on checking these electrolytes, 3 electrolytes. So the potassium, magnesium and calcium, right? So you have to learn hypokalemia, hypomagnesemia and hypercalcemia. These are the 3 electrolyte disbalance which can lead to Digitalis toxicity. So apart from these electrolytes, there are some drugs also, quinidine, thiazides, verapamil, amiodarone. They also leads to Digitalis toxicity. There are certain diseases. If the patient already have renal failure, if they already have hepatic failure, right? If the patient have hypothyroidism, WPW syndrome, AV block, so they can also lead to Digitalis toxicity. So there is a mnemonic I am having for it. A minute, let me show you the mnemonic first. I am having a mnemonic for you. What is the mnemonic? This is the mnemonic. So these are the contraindications of Digitalis, you can see. So what is the mnemonic? The mnemonic is contraindicated in weak heart. Contraindicated का जो C है, that stands for carditis. If the patient already have myocarditis, don't give Digitalis. इनका जो I है, that is increased calcium. Don't give in hypercalcemia. Weak का जो W है, that stands for WPW syndrome. H जो है, heart का जो H है, that is hypokalemia and hypomagnesemia. E is elderly. Elderly patient में नहीं देना है. A is AV block. Partial AV block will convert into complete AV block. R is renal failure. And T is thyroid disorder. So can you tell me the full form? Contraindicated in weak heart. HEART. Contraindicated in weak heart. This is the mnemonic, right? So these are the contraindications of digitalis. Can you help me with the full form? C is carditis, myocarditis. I is increased calcium. W is WPW syndrome. ठीक है. H is hypo. दो hypo हैं. Hypokalemia, hypomagnesemia. E stands for elderly. Elderly, right? A मैं भूल गई. What was A? R was renal failure. And T is thyroid disorders. T was thyroid disorder. So that is the mnemonic you have to learn. A, what was A? HEA. A is AV block, partial AV block. So this is a mnemonic you have to learn. The weak heart. Yes, contraindicated in weak heart. So yes, Sachin, contraindicated का C, in का E, weak का W और heart पूरा HEART. Try to say the full form again and again. These are the contraindications of digital. So we have learned the mechanism of action, uses, adverse effects, contraindication, classification, everything. So this completes digitalis. Give me a thumbs up. Give me a thumbs up. So this chapter is completed from my side. So I'm ending this session. I'm not giving you MCQs for practice, but have you got it? Give me a thumbs up if you got it. Still, if you have any doubt, even a slightest doubt, don't forget to text your doubt on this number. My contact number is 9833032948. It's my personal contact number. You can send your study related doubts in patho, pharma, micro, PSM and medicine on this number. Whenever I will get time, I will revert back to you. Don't forget to tell me your college name, your university and your probable exam dates, right? Whatever exam you are targeting, whether it's a university exam or any competitive exam. So I can help you with a proper schedule or important questions for your exam, right? And in this session, in the comments, there is a link which is pinned. See right now, there is a link which is pinned. So in that link, you can connect with me. If you click on that link, it is a link tree. So on that, Insta link is given, Telegram channel link is given, WhatsApp group link is given, Facebook link is given, YouTube link is given. So all the links are given there. You click on all the links and join me on all social media platforms so that I can share you more and more study related useful materials that can help you to crack your exams easily, right? And please share that link tree with all your friends, colleagues, everyone, basically all the medicos only. No, don't share it with non-medicos. So all the MBBS medicos only from wherever the globe they belong to. So that will be useful for them. Thank you very much. I would like to see you again tomorrow also, not tomorrow, a day after tomorrow on Monday. We will meet again in the live session with another important topic. You are free to tell me the list of the topics. The list of the topics from these subjects, I will try to schedule those topics in the. Thank you so much. Study hard. Wishing you all the best for your exams. Bye-bye. I'm ending this session.